Hello. Okay, so first of all, I just wanted to talk to you a little bit about where I work, really, so you know kind of my background. I work at the Cerebral Centre for Neurodevelopmental Disorders, based at the University of Birmingham. The director's Chris Oliver, who I'm sure you've heard talk at some point before. Our work basically focuses on children with intellectual disability and the problems faced by children with intellectual disability, autism, genetic syndromes, and the problems faced by their parents and carers and those kind of things. So it just gives you an idea of what my background is and where I work. Okay. So today I was asked to talk to you a little bit about a project that I've been involved in for the last 18 months, and that's remote consultancy for self-injurious behaviour in children with autism spectrum disorders. Now, it's only a pilot study, so the way I've decided to present it today, because I thought it'd be a bit more interesting, is clinically as opposed to very overly in an overly research way. So if anybody's interested in the other side of it, a bit more research, then please either come and talk to me at the end, or you can always email me. I think my email address is in your pack, so feel free to email me if you have any further questions. Okay, so myself and Chris Oliver were the PIs on this project, the principal investigators. Rachel Carter and Gemma Warren were volunteers at the centre, and Vasiliki, Alicia, Joanne, Janet, Simon and Nicole, I'm sure some of you are familiar with, who work for the National Autistic Society in schools. They were our consultees. Okay. So I'll tell you a little bit about self-injurious behaviour. So if you have a quick look at the definition there by Murphy and Wilson. There's lots of definitions of self-injurious behaviour, but this is quite a good one. So any non-accidental behaviour initiated by the individual which directly results in physical harm to that individual. So if you have contact with children with intellectual disability or autism, you've probably seen lots of examples of these behaviours, so head banging, chin hitting, maybe hitting heads on tables, those kind of things. So below you'll see a chart which basically shows the likelihood of children within a particular group of showing those kind of behaviours. So the first one is autism spectrum disorders, the second one's Down syndrome, and the third one's Fragile X. So basically what we can see here is that children with ASD don't have a particular common form of self-injury. It occurs in all forms, and this contrasts with something like Fragile X syndrome, where children predominantly bite themselves, usually the back of the hand. Okay. So how common and persistent is self-injury in autism spectrum disorder? Okay, so what we know is that self-injury occurs in about 50% of children with autism spectrum disorders. And on the graph, you can see that's compared to children with general intellectual disability and also with children with Down syndrome. So it's almost twice those with kind of general intellectual disability. Okay. So this evidence is across 2 surveys that we've conducted, and it tells us that, 2 surveys that we conducted, and across causes of intellectual disability. Basically, it's about 1 in 2. What we also know is that about 80% of children with autism who have self-injurious behaviour will still have it 3 years later. In terms of we talked about the fact that 50% of children with autism have or show some kind of self-injurious behaviour. In terms of who will develop self-injurious behaviour, what are the factors involved in the 50% that actually show self-injurious behaviour? From recent research, we think possibly degree of intellectual disability, possibly the presence of repetitive behaviours, and possibly also the presence of particular health conditions. Okay. So you'll see in the graph on the bottom right, basically this is general intellectual disability, but basically if you look, we've got children who are not very able at all, those who are partially able and those who are able, and the amount of self-injury in the not able group is much, much higher than the other 2 groups. Okay, so what do we know about the prevalence of self-injury by age? Well, this is general intellectual disability. We think it's kind of relevant to the autistic spectrum population as well. What we do know is that it peaks at around kind of the mid-20s and then tails off. Okay, and then when we look at the development of self-injury for individuals, self-injury very rarely appears severe from the very, very beginning. So what we normally find is that it's occurring and not really identified as a problem initially. And then we find that it's identified as a problem requiring management. And then as a problem requiring intervention. And then as a problem requiring additional resources. And finally, as a problem requiring specialist placement. So with the high prevalence, we know that self-injury possibly increases with age up until the mid-20s. We also know that self-injury doesn't develop initially as a severe behaviour. It's something that starts off as not so severe. And I think this is a pretty good case for early intervention, really. Okay, this is a model which was developed by Professor Chris Oliver, and basically it talks about there may be lots of other or there may be other causes and drivers of self-injury, but these are the ones that we've focused on recently because these seem to give a bit more insight into possible assessment techniques and also possible intervention. So we've got, first of all, pain. The presence of pain and discomfort is a possible cause or driver of self-injurious behaviour. We also have self-injury as a learned behaviour. Excuse me, I'm going to talk in a bit more detail about this as we go along. And then we also have the impact of behaviour dysregulation on the development of self-injury. So let's talk about pain and discomfort first of all. So what we did find recently is in a group of under 5 children, the presence of particular health conditions increased the likelihood of children developing self-injurious behaviour. What's difficult in the autism spectrum disorder population is that communication is often impaired, and the ability to actually kind of verbalise and vocalise complaints of pain is therefore not always possible. So as a result, it's possible that in this population particularly, there are lots of kind of unidentified and untreated kind of health conditions. Okay, so the kind of things that you would be looking for if you were assessing self-injurious behaviour, the kind of things you would be looking for if a child was experiencing pain would be the fact that self-injury wouldn't be related to particular environmental events, so it would occur across different environments. Children often appear inconsolable for hours or days, and then all of a sudden there's nothing for a while, and then all of a sudden it'll occur again. Kind of things to look for in terms of pain-related behaviours in non-verbal, what we know in non-verbal populations or populations with limited verbal ability are changes in vocalisations, changing in facial expression. So you might notice, I don't know whether anybody knows, but there's a universal sign of pain, which is 2 furrowed lines down the middle of the forehead. So looking for that in children that aren't able to complain about any pain they may be experiencing. You may see differences in sociability, so children might withdraw or be irritable. You might notice differences in activity. So recently, there were some assessments that are showing that overactivity, you would think it might be underactivity, but it's actually overactivity is sometimes suggestive of pain. Any kind of flinching or protective guarding of particular areas of the body, and also changes in eating and sleeping. Okay, so common painful conditions include ear infection, tooth decay, and also, and this is a big thing in children with autism spectrum disorder, and that's gastrointestinal problems, particularly reflux. Okay. Often, we're not actually involved in this, but often if a child suspected of actually experiencing some kind of pain, a GP will suggest the trial of analgesics, so painkillers, to see whether, and ask parents to kind of keep behavioural records to see whether there's any difference across. We sometimes are involved in the evaluation of that, but obviously we're psychologists, not medics, so we can't prescribe that. Okay, so give you a bit more information about gastroesophageal reflux distress. Because obviously children can't verbalise feelings of, the most common symptom of reflux is heartburn, and in typically developing adults, typically if they were presenting with heartburn, they would be assessed for gastroesophageal reflux. But because children can't actually vocalise that, the kind of signs that you might be looking for, we think, for reflux are these. And this is the gastroesophageal distress questionnaire developed by my colleagues at the centre. And we have a clinical cut-off point where you have to score kind of 5 and above in order to be suspected of reflux. Okay, so this graph is from Caroline Richards' PhD, and basically what she found was that of all of the population of ASD who actually show self-injurious behaviour, just over 60% of them scored above the clinical cut-off on the GDQ. Okay, now this is this was a little boy who participated in Caroline's research. He was 9 years old, and he showed the following self-injury. He hit his body, he head-banged, he hit himself with hard objects, he bit his hand, he bit hard objects, and he scratched his face. And when Caroline went to observe him, his behaviour struck her as being particularly severe, and she had to stop a lot of observations and tasks that she had planned with him, and it would happen out of nowhere, and he was obviously often inconsolable. And so he went to see his GP. I'm not sure whether he was actually... the diagnostic technique for reflux is typically pH level monitoring, which is quite invasive. So I'm not sure whether he underwent that or whether his GI or whether his GI specialist just suggested omeprazole, which is an anti-reflux medication. But if you look at the GDQ score before and afterwards, you'll find that pre-intervention he was scoring quite highly, and post-intervention not so highly. Unfortunately, we didn't get any data on his levels of self-injury before, pre and post. So let's talk about self-injury as a learnt behaviour. So self-injury is a learnt behaviour. Basically, if a child shows self-injurious behaviour and it's followed by some kind of rewarding consequences, the chances are that it will become a learnt behaviour. Talk in a bit more detail and give you a few more diagrams to let you, so you can understand what I mean a little bit later. But the kind of things you're looking for if self-injury is a learned behaviour, and it doesn't necessarily have to start off as a learned behaviour. Some people think that it could start off as a pain-related behaviour, which then develops into a learned behaviour. So you have a child who's experiencing pain, maybe hits his ear, mum responds to it, and then it becomes kind of a learned behaviour. Okay. So how do we know if it's a learnt behaviour? So you would probably compare the rates and types of behaviours across environments, and keeping records or observing. The kind of pattern that you would be seeing is that self-injury occurs in some environments but not in others. And also they're usually associated with kind of social events, so things like low attention or demands or denials or something like that. So just to give you an idea, so what I actually said was that when something rewarding followed an episode of self-injurious behaviour, there's kind of two types of consequences following self-injurious behaviour in terms of rewarding it. So the first one is what we call positive reinforcement, and that's when we add something to the environment which then strengthens the behaviour. So, for example, if a child pulls their hair and an adult turns and interacts with them, then we might say that behaviour could be maintained by access to adult attention, if you see what I mean. And what we actually did was we added something after the behaviour, and as a result, the behaviour increases. Or next time that situation occurs, the child is alone, they may pull their hair in order to get access to adult attention, if you see what I mean. Okay, the next kind of reinforcement that we deal with is negative reinforcement, and this is when we remove something aversive for the child, and as a result we strengthen the behaviour. So for example, if so let's say there's a loud noise in the classroom and the child starts to self-injure and the teacher turns the music off, for example. Actually what we've done is we've removed something aversive from the environment, but still as a result next time the child might decide to pull their hair in order to have the music stopped, if you see what I mean. I'll talk about extinction in a bit more detail later, but extinction, you might hear me talk about it, so you really need to know what it is first. Extinction is the removal of reinforcement following a behaviour. So basically it's not, I know a lot of people, there's a few misconceptions with extinction where you ignore the behaviour. That's not what extinction is. Extinction is when you remove the reinforcement of a previously reinforced behaviour. So in the two examples that I gave you, in the first example where adult interaction possibly maintain the behaviour, so you remove adult interaction. And in terms of the second example I gave you where you remove something, so we talked about removing the music, in that situation, extinction would mean leaving the music on. So it's just, so you've got a basic idea. Okay, so common functions common functions for self-injurious behaviour generally seem to be, and for children with intellectual disability generally, seems to be access to attention, adult attention, access to tangibles, so that can be access to items, location, activities, anything like that. The other common one is demand escape. So basically escaping from a teaching situation or escaping from a self-care task or something like that. In terms of autism-specific functions, during Caroline Richards' PhD, she came up with a number of other functions that she thought were highly likely, considering kind of the symptoms of autism and the difficulties often associated with autism. And specifically, that's access to rituals or routines, also social escape, so escaping from social attention, and also sensory escape, so possibly escaping from loud noises and those kind of things. She also expected to see a lot of transition-related self-injurious behaviour, but actually I'll talk to you a little bit later about how this is so, but transition-related behaviour can actually be talked about in terms of positive and negative reinforcement, and it's a case of identifying what is it about the transition that's actually leading to the self-injurious behaviour. So, I'm going to start up in the top left-hand corner. Okay, so we have an interruption to a child's routine. So let's say a child likes putting the Lego away in a particular way, but it takes half an hour, and really the child needs to go out to play. So a teacher might say, okay, it's time to put the Lego away now. And then because you've interrupted the child's routine with the Lego, you may see some self-injurious behaviour. As a result, that's aversive to the caregiver. So this is also going to talk about the mutual reinforcement between caregiver and child. So it's going to be quite aversive. Staff members going to be concerned or frustrated, anxious or confused, distressed, which then leads to an action, or a parent, which then leads to an action. In this case, it's probably going to be to disengage and reinstate the routine. And in this case, we've rewarded the behaviour, and because we've taken something aversive away, it's negative reinforcement. And what we do is we increase the chance of self-injurious behaviour next time there's an interruption to the routine. Another example is an unpredictable environment. So there's a change in the child's classroom, for example. There's you see some self-injurious behaviour because it's not the child's typical classroom. Again, it's aversive to the caregiver or parent. They decide to act, so they remove the aversive stimulus, and therefore, so for example, the child's allowed to go back to the other classroom. So they've rewarded the behaviour. It's negative reinforcement because we've removed something, and we're increasing the chance of self-injurious behaviour next time there's an unpredictable environment. So do you kind of get that kind of idea? Okay. Okay, so very quickly, have a look at these behaviours and have a think about which ones you would be most worried about. So which ones are you likely to respond to? And therefore, which ones are likely to be reinforced? So it gives you some idea about how severe behaviours develop. Okay, so for example, I'll leave you with that just now. Okay, so Caroline Richards' PhD, she looked at 10 children in National Autistic Society schools who were showing some kind of self-injurious behaviour. And first of all, there's a particular method of assessment that we called analogue or experimental manipulations, and it's function analysis. And basically, what the aim of the assessments are to try and find the function of the behaviour. So in standard experimental conditions, you might have a high attention condition, you might have a low attention condition, you might have a demand condition, and possibly a tangible condition. And in those conditions, in high attention, it's what it is. So the researcher or the clinician would talk to the child and kind of follow the child's lead. In the low attention condition, the clinician or researcher would be busy doing something, and the child would be left, in the same room, obviously. And then in the demand condition, they would try and teach a task, like an educational task. And in the tangible condition, the child might, first of all, will be allowed access a preferred item, and then it will be time to end the item. And basically, in these assessments, they would spend between 2 and 10 minutes in each condition, and there would be a couple of repetitions of each condition, and you would look at the levels of behaviour in each condition. And when the levels of behaviour are high, you can expect that that's the function of the behaviour. And these conditions aren't anything that the child doesn't experience on a daily basis in the classroom. They're not extreme experimental conditions. They'd be in the child's kind of school. Okay, so she conducted these standard experimental function analysis. You can see that properly, but basically she couldn't identify function in any of them, in any of the 10 children. So then she added the ASD modified experimental function analysis, so it was the interruption to routine, the social escape, and all those. And she managed to identify function in 6 children. 2 were sensory escape. 1 was actually access to attention, but under very specific conditions. And the others were access to repetitive behaviour, so access to routines and repetitive behaviours. Okay. So behaviour dysregulation, very, very quickly. So what we know about self-injury is that the presence of high rates of repetitive behaviour is strongly linked to the development of self-injurious behaviour. And we think this might have something to do with a lack of inhibition. And obviously with the problems reported with executive function, particularly inhibition in children with ASD, we think that possibly this is kind of related to the development of self-injury. So the kind of things to look for then. So the other thing to look for is self-restraint behaviours. So these are behaviours when children are trying to restrain themselves from actually self-injuring. So the kind of things you might see are children wrapping their hands in their clothes, wrapping their hands in furniture, holding their hands behind their back, those kind of things, putting their hands in their pockets, those kind of things. The other thing to mention is that it can actually be symbolic as well. So just because it's not actually wrapped up, it could be that the child holds on to something specific. Okay, so the other thing that you might see is actually a child seeking restraint from others, so asking for them to cuddle them or sit on their knee and those kind of things, and also a preference for imposed restraint. So I don't think we met any children at the schools we visited who actually wear splints and things, arm splints or helmets. But actually, children who kind of put their arms out for splints to be administered, that's kind of a sign that you should be looking to see whether that's actually kind of preferred restraint, if you see what I mean. And here's some examples. So we've got a picture of a little girl holding her arms out very compliantly to have the splints put on. And then some pictures of children self-restraining, so holding their hands behind their back, putting them down their shorts, inside their jumper, inside their trousers, those kind of things. So very quickly, in terms of the assessment of self-injurious behaviour, we know that 60% of children with autism who show self-injury may be experiencing reflux. We also know that out of 10 children, I mean it's very small numbers, but out of 10 children, we managed to identify function for 6 children. And if we can identify function, generally we've got lots of interventions at our fingertips that we can, help these children to reduce their self-injury. We're not so sure about the rates for behaviour dysregulation yet. So very quickly, so we know that now that self-injury could be very treatable. This isn't autism specific. This is based on a survey of parents in Birmingham of children with general intellectual disability. And basically, if you look at the self-injury category, these are parents who are in need of help with their child's self-injurious behaviour, and it's almost 80%. When you actually look at who actually receives help, it's kind of about 40%. So there's 50% of parents in Birmingham who actually aren't, probably could be representative of elsewhere, but basically there's 50% of parents in Birmingham who aren't actually receiving that help. And we kind of ask a question, why is that? Is it because of long waiting lists? We don't know the answer to this. Anecdotally, we talk to parents who say that they're a little bit disillusioned with services, that perhaps they don't always know what to do, and then following that kind of cycle of disengagement with services, we don't know. But in addition to that, if you look at the amount of research on self-injurious behaviour out of all of the autism research, from 2001 to 2005, the percentage was about 1%. Of publications, and from 2006 to date, it's less than 1%. So actually what we know about self-injurious behaviour is probably very little. And if you think about the research to practitioner link, which is supposed to happen, if there's no research, then how do practitioners know what to do? Okay, so what to do? Just very, very quickly. So when we talk about self-injurious behaviour as a learnt behaviour, and self-injurious behaviour which is related to behaviour dysregulation, generally what we would do in the latter is, in terms of intervention, is to teach tolerance to delay, and also have some kind of self-restraint fading or kind of mechanical restraint fading, those kind of things. And they're areas of behavioural expertise. And what it seems over the past kind of 20 years is that behaviourism has kind of gone out of fashion really, and isn't really taught in undergraduate psychology courses, isn't really taught on clinical training courses or educational psychology courses. And so we're not actually, and we don't know the answer to this, but I guess it would be nice to know whether people actually have those behavioural skills. Okay, so what do we know? We know a high percentage of children may be treatable. Self-injury might be treatable, but this is dependent upon behavioural expertise. Possibly a lot is dependent upon behavioural expertise. We know that behavioural expertise is scarce. Behavioural expertise needs to be disseminated to those who need it most, but how? Can we do it by consultancy? And who do we consult to? Do we do it with families, schools, psychologists? What we do know is that research tells us that external behavioural consultancy is most effective when there are people who are on site trained in the techniques. Behavioural methods, procedures can be complicated and they require high levels of precision, and therefore frequent and ongoing feedback is really required. The difficulty is that those who have the behavioural expertise are only based in one place, and the people that need it are geographically widespread. And this is a problem we've had at the Cerebra Centre, in that when we want to do intervention type research, because people are so geographically widespread and there's not many of us, we kind of up and down the country, and it's financially and also time costly. So we decided to try remote consultancy. Now I'll talk to you about the current project. Okay, so can remote consultancy lead to, this is what we wanted to know, can remote consultancy lead to a reduction in self-injurious behaviour? Can we train school staff to independently assess the causes and drivers of self-injurious behaviour, analyse and interpret the results of assessment, and design intervention programmes to reduce self-injurious behaviour? And also, can we teach them to evaluate interventions? I guess the other thing that we really needed to know is the remote consultancy model feasible and practical? Schools, we chose 3 schools, NAS schools, to participate in the research because they'd previously participated in Caroline Richards' project, and they'd got as far as the end of assessment, and Caroline had sent out some really good feedback with reports with advice, but we wanted to actually give some hands-on kind of intervention advice. Okay, so in terms of consultees, we asked for members of staff who were involved in training kind of staff on challenging behaviour, who also whose role was actually to do with challenging behaviour on a daily basis. But we also asked that people, because we were going to run kind of the equivalent of a master's level course, we asked that consultees actually had a degree or above. Okay, and also that they could commit 1 day a week to the project. Okay, so in terms of children, we recruited children who presented self-injury at least daily, who had a diagnosis of autism spectrum disorder, who had no known additional genetic disorders, who had a severe intellectual disability, and also were under 16 for the duration of the study. And we recruited 6 children and 6 consultees. So here's just an overview of the children. Children were aged between 8 and 15 at the beginning of the study. We had 1 female and 4 males. We also had you'll notice that participant number 4 isn't there. Unfortunately, participant number 4 withdrew just before the study actually began. Okay, so this was kind of, I'll just explain this really, but there were 2 consultees at each school, and each consultee had their own kind of participant. And the aim was for them to assess the children's behaviour, formulate interventions, deliver interventions, evaluate them, so almost like a mini case study really. So consultancy was delivered by training workshops. These were 4 lots of 2 days at the University of Birmingham. These were lectures, group discussions, very much like university seminars really. We had monthly 1 to 2 hours individual consultation via WebEx, well that was the plan. And we had fortnightly email and drop-in clinics, which again was individual consultation. And then we also had 2 site visits planned for each school just to get to know them and help out if they ended up having to do interventions which required the use of Extinction. I'm not going to go on too much about this. Basically, training content was teaching consultees how to assess challenging behaviour, what kind of interventions to match to function, data collection techniques, all those kind of things. So the project ran from November 2010 until July 2011. There was a total of 31 weeks of consultancy and training, excluding school holidays. And I think assessment occurred between January and May, and the interventions occurred between June and July. We had to evaluate the interventions quite early, so at the end of July, when really interventions hadn't really been running that long, but okay. So how were we hoping to help? I guess the idea was if children were identified as having pain-related self-injury, we would very much only be able to help in a signposting capacity, so referring children to GPs, helping consultees write letters of referral to GPs and consultants, also helping collection of supporting video footage. So if we thought that a child might have reflux, we would help them write up the GDQ results, help them collect some video footage of children when we thought they were experiencing pain, those kind of things. And then in terms of behavioural intervention for unlearning learnt self-injurious behaviour and also behaviour dysregulation, we would be kind of using operant principles, so principles of negative and positive reinforcement, and also restraint fading and teaching tolerance of delay. Okay, so assessment, basically there were 2 stages to assessment. The first was informant-based measures, so questionnaires and interviews to parents asking them about their child's self-injury, or teachers, interviewing teachers. The second was typically when we conduct an assessment of self-injurious behaviour, we use the technique which I described earlier, which is analogues, which is experimental analysis. However, because we weren't actually going to be on the premises when they were actually going to be used, some of the schools were a little bit reluctant to use the technique. And also, generally, analogue procedures tend to have quite low acceptability, even though they're the most robust method of kind of ascertaining function. And also, it's been shown in the research that when functional analysis is conducted, the chances of you finding the correct function and identifying the correct treatment are much higher. But we decided to pilot a different type of assessment. And this was basically asking teachers to collect footage of children under particular conditions, which I'll talk to you about in a moment. But these were naturally occurring conditions. So basically the consultee would be in the classroom with a video footage, with a video camera, basically ready to film children under like teaching situations or situations where the teacher was busy, those kind of things. But I'll give you a bit more of an in-depth explanation. Okay, very quickly. These were the informant-based measures, some for pain and discomfort, some for functional assessment, some for behaviour dysregulation, and just something like an outcome measure, which was basically the challenger behaviour interview, which looked at the severity and frequency of challenger behaviour. Okay, I'm not going to go into too much detail. If anybody's interested in these measures, feel free to email me. So these are the conditions under which we ask children to be videotaped. So that's a demand escape, low attention, access to tangibles, access to rituals and routines. And we basically asked for about 3 samples, 3 5-minute samples of each of these situations, and also transitions. All consultees completed the informant-based questionnaires and interviews. 2 of the consultees managed to do the collection of observations of children under those conditions. And for the other 3, myself and my colleagues actually went in and did some direct observation for children. So these are basically what we found from the assessments. So as you'll see, all children actually there was evidence of function in all children. There was evidence of pain and discomfort in 2 children, but we think that was generally managed by medication. And then in terms of the evidence of behavioural dysregulation, we had a questionnaire which asked about self-restraint behaviours. We didn't have none of the children showed up as showing any of those self-restraint behaviours. But what we did notice through observation was that 3 of the children were actually intolerant to delay, which is kind of evident in behavioural dysregulation. So here are the functions that we found for each participant. I don't think you need to go into the detail too much. Just notice that there's multiple functions for each participant. Okay. In terms of interventions, the kind of model we used was to basically identify contingencies maintaining self-injurious behaviour, so finding out the function of the behaviour, then trying to identify and train a replacement behaviour which would achieve the same function, but then also identifying methods whereby antecedents, behaviours and functional consequences could be altered so that the problem behaviour becomes irrelevant, ineffective and inefficient. I'll explain how we did that. So in terms of antecedents, basically, for example, if a child liked music, for example, and in order to maybe a member of staff used music when a child was self-injuring, if you see what I mean, just to kind of distract them a little bit. It could be that actually the self-injury develops so that actually they show self-injury in order for music to be played. And so in that kind of situation, what you have to think about is, okay, can we increase access to music in short, sharp bursts throughout the day? So we're thinking about antecedents before the behaviour occurs. Can we increase the amount of music the child has through the day, kind of break the association between self-injury and music? And can we also increase the predictability of reinforcement? So let the child know in some way when music was going to happen by using visual schedules or something. And then also for negative reinforcement. So for example, if a child felt that a task was particularly aversive, finding out why that task was aversive. Was it too difficult? Did they not like the feel of the materials? You know, kind of trying to alter that first. And then in addition to that, we would be reinforcing a replacement behaviour, and we would also want to stop reinforcing self-injurious behaviour, which we call extinction. Extinction, which I've talked about, sometimes you see a burst of behaviour or an increase in the intensity or frequency of a behaviour when you stop reinforcing a behaviour. All schools were very, very, very aware of that and had very detailed plans to cope with that. You also sometimes see emotional or novel behaviour during those times, like crying or new kinds of topographies of self-injury or aggression. Okay, so I'm just going to skip through these. Transitions. What we looked at for transitions was it all transitions that the child the child had difficulty with, in which case it was insisted upon sameness or behavioural rigidity? Was it that there were unplanned transitions, so that was related to predictability? Was it specific transitions for one to another? Okay. Or was it a physical difficulty crossing the thresholds? Okay, participant 1. I'm not going to have time to show any video footage, unfortunately, so I'm just going to give you an explanation of some of the participants. So the first participant showed hand biting and dropping to the floor. She showed lots of functions. We decided on a setting at the end of the day when the participant was getting ready to leave school, and this was a particular time when self-injury would occur, and she would drop to the floor and she would bite her hand. And basically we looked at this footage over and over again. There was a couple of different, she was filmed over 3 or 4 days, and we had a look, and basically we think that it was a busy time for all staff, and she was trying to gain staff attention during this time. Staff were trying to put a coat on, and she didn't want to kind of engage. She wanted to play with the staff. Also, she had a preferred item, so her preferred item was her bag. And at the end of the school day, the routine was to put her coat on and then put her bag on, but it wasn't done consistently in that order. And if the bag wasn't there, she'd find that she'd get particularly upset because if she couldn't see the bag and she was going home, she thought she was going to go home without it. And then also there was a tolerance to the delay issue, so there was a wait before she actually left the classroom. And because of her behaviour, staff were anxious that if they didn't get her ready early, she wouldn't be ready for the bus. So basically we implemented a very short independent schedule, which was supposed to be, there was also about 3 staff working with her at the end of the day. So we had a very short schedule with a coat on, bag, and then a little symbol which she would hand to the person at the door to say, I'm ready to go to the minibus now. So it kind of got rid of the wait. And she was basically took through that non-verbally with no interaction from staff until she was finished the schedule. And also there was a bit more consistency about when the bag appeared, if you see what I mean. So it was coat on, bag on, and the child would basically follow the schedule. Sorry, I'm rushing through this now. Okay. Participant 2 was slapping. Basically, he slapped his head, and this usually occurred on the transition from the lunch hall out to the playground. And at first, we thought it was a transition-related behaviour, and we thought it was a threshold behaviour because, and it possibly started off like that. There were times when he found it hard to kind of cross over a threshold, like cuts in the carpet, or if there was sunshine was shining in, there were shadows. But it became apparent very quickly that what happened when he stopped at a threshold was that staff would talk to him and coach him and give him lots of encouragement to cross the threshold. And actually, what we found was maintaining the behaviour was an increase in social attention. So when he went outside, when he was going outside, there was a big drop in social attention because it was lunchtime and a lot of staff were on their break. And what he was trying to do was maintain social contact inside. So basically, we again ensured that staff were giving him lots of social attention when he was transitioning appropriately, and if he stopped, they would withdraw the social attention until he was ready to go, but keep reminding him it's time to go. And when he got out to the classroom, we taught him to actually approach a member of staff and request. He liked playing hand games, so we taught him so that when he got out there, there was some kind of reinforcement after the transition. Participant 3, this was basically around the swing. There were lots of other issues going on with this young man, but we decided to take this as a very low-risk intervention. We were really short on time. This particular child was trying to access the swing in quite a dangerous way in the playground, so he would try and pull another child off the swing while they were on it. And we wanted to teach him to request the swing, and he was showing self-injury when there was someone else on the swing, if there was any tolerance, if there was any delay. So we taught him to request the swing using a PEC symbol, and also later we were aiming to teach him to tolerate delays on the swing. Yes. Okay. Shall I just wind up? Yeah, that's fine. Okay. Participant 5 was a general curriculum enrichment, environmental enrichment programme with loads of reinforcer assessments. This was much more intense than the other 3 interventions because it was a full day, full school week intervention. Let me just show you the outcome data. Outcome data for all children, as you can see, is quite positive. We managed to reduce self-injury in all cases. In some of the more complex cases, 5 and 6, it wasn't so marked a reduction. Okay. So I guess the answer is yes, we can reduce self-injury in all participants. We managed to reduce self-injury in all participants. We didn't address all of the functions that we actually wanted to because there was just no time. We also managed to reduce the number of staff working with children during those times, and we managed to teach at least one communicative response to each child. Remote consultancy appeared to be feasible and practical. The only slight issue was that consultees couldn't always allocate a full day to the project, in which case we fell behind on a few issues. Other than that, very positive. Okay, I'll finish there.